and I can unmute you. So we really want to try to get that going. So let me just read you a little bit of Dr. David Mintz's bio. It's a very short bio. He's a graduate of the University of Miami School of Medicine and Cambridge Hospital Austen Riggs Center Combined Residency Program, which is how we know each other. He completed a fellowship in psychodynamic psychotherapy at the Austen Riggs Center, where he remained on staff and currently serves as Director of Psychiatric Education, Associate Director of Training, and is a treatment team leader. In his work at the Austen Riggs Center, Dr. Mintz is involved in very complex and multiply comorbid patients who have proved resistant to other treatments. These patients often have extensive histories of unsuccessful medication trials. In order to address the problem of pharmacologic treatment resistance, Dr. Mintz and colleagues at Riggs developed a set of psychodynamically informed technical principles rooted in the evidence base regarding psychosocial aspects of medication. Dr. Mintz has published and presented widely on this topic. He is interested in psychodynamic aspects of medical education, professionalism, and approaches to complex treatment for psychiatric illness. He's the recent past leader of the Psychotherapy Caucus at the American Psychiatric Association, which is very important, and is on the Medical Student Education Committee of the American Psychoanalytic Association. So David and I go back to the training at Cambridge and Riggs. I'm really delighted to have him here. I think he's actually working on his book this week, which is going to be reflective of some of what he's talking with us today about. And it's been, I've always appreciated his mentorship and his thoughtfulness and his devotion, not only to the work, but to working with really people that are really deeply suffering, and is really, I think, making his mark by training people. This is not easy. Educating and training people in how to sit with and understand people that are very difficult at times to understand. And I think one of the reasons it's great to have him here presenting at at Hartford Healthcare, the Behavioral Health Network, and particularly the Institute of Living Grand Rounds, is that this is a place which has, in my view, a deep clinical soul, and I think will resonate with him in his presentation today. So he'll be talking with us about the psychosocial dimension of psychopharmacology, something I think we should spend a heck of a lot more time talking and thinking about. And so with that, David, I'm going to try to turn it over to you, and we'll see this work.
Okay, thank you. Hopefully people can hear me. I'm starting to share my slides, my screen now.
Perfect.
So I think I'm supposed to start with this slide so you guys can do your little snapshot of the activity code there. And I will say that, as John was saying, that today we're going to talk about an aspect of psychiatry that I think has been woefully ignored in general. And, it's something that makes a lot of sense, but so much of our focus is on the what to prescribe part of things and less on the how to prescribe. So I'm going to talk today about the evidence base, about what we know about the psychosocial dimension of psychopharmacotherapy. I will add that I guess I do have some conflicts, but none of them are financial, at least. It's just the usual ones. And nobody else involved in the planning of this event appears to have had any commercial financial conflicts as well. I suppose I should also maybe start with a couple apologies. One is that I predict you're not going to learn a lot today. It's not that what I'm saying is not important, but I have a feeling that much of what I'm going to say today, you know already as human beings about the importance of this stuff. It's just that we're operating in systems of care that put us under the kind of pressure that make us not know what we know about what humans need from treatment. So in that sense, you might not learn a lot. I also want to apologize for my first slide, which contains not one, but two presentation faux pas. First, it's a very busy slide because there's a lot of words on it, which one shouldn't do. And second, when speaking to a psychiatric audience, one should be careful about using the word Freud, much less starting with that word. And that's where we're going to start with, because Sigmund Freud in 1905 said basically what summed up what I want to say today, which is that we physicians cannot discard psychotherapy, if only because another person intimately connected, concerned in the process of recovery, the patient has no intention of discarding it. A factor dependent on the psychical disposition of the patient contributes without any intention on our part to the effect of every therapeutic process initiated by a physician or nurse or psychologist, but we're talking about medications right now. Most frequently, it is favorable to recovery, right? So Freud is talking about what later came to be called the placebo effect. But often, it acts as an inhibition, so the patient's psychology gets in the way of their benefiting from our medical treatments. All physicians, he goes on to say, therefore, yourselves included, are continually practicing psychotherapy, even when you have no intent and are not aware of it. So basically, every time you talk to a patient, doing or how you think about what you're doing or what the plan is, the patient is making psychological sense of that is affecting how they're going to use the treatment. It is a disadvantage, Freud goes on to say, however, to leave the mental factor in your treatment so completely in the patient's hands. Thus, it is impossible to keep a check on it, to administer it in doses, or to intensify it. And he concludes that is it not then a justifiable endeavor on the part of the physician to seek to obtain command of this factor, to use it with a purpose, and to direct and strengthen it? So that's what I'm going to be talking about today, is how do we mindfully prescribe in a way where we take what we know about humans and what we know about the evidence base and do it in such a way as to optimize the chances that there will be a good outcome. And this is important, of course, because we're in an era, I think we're just coming out of an era of much more reductive, a much more biologically reductive approach to psychiatry. And, certainly beginning in the 1990s. In 1990, then President George H.W. Bush, in Presidential Proclamation 6158, declared the 90s to be the decade of the brain. And for those of us in my generation, that this was a time of tremendous excitement about neuroscience and pharmacotherapy. We were just beginning to be able to look into the brain and see what was happening there with functional neuroimaging. We, starting in the 80s, for the first time, we were actually designing psychiatric medications as opposed to what had happened before that, which is all of our psychiatric medications before that had been basically discovered by accident. So there was a lot going on, and the 90s saw a shift from a biopsychosocial model to what Stephen Sharfstein, former president of the APA, called the bio model of psychiatry. This was a time when things like the 15-minute med check was invented, as if that's all we're doing is checking somebody's meds or their symptoms. And interestingly as well, something happened in our literature, which is that meaning effects basically dropped out of our literature for about, and they're still not really back in the same way, but for 20 years or more. So in this meta-analysis, interesting meta-analysis, that they weren't looking for this, but Chong, Aslani, and Chen did a meta-analysis of psychosocial interventions intended to improve adherence to antidepressant pharmacotherapy. There were 26 studies that met criteria for inclusion in the meta-analysis. And just as a side finding, or I don't know if they even found it, I found it in the paper, of those 26 studies, 25 of them came out of the primary care literature, and only one came out of organized psychiatry. And I take this to mean that we were so preoccupied with kind of the biomedical aspects of the doctor of pharmacotherapy that other fields were the ones who were left to be thinking about the psychosocial aspects. And for all this excitement, however, I think the evidence is that patients are not a whole lot better off now than they were 30 years ago, except that the outcomes aren't necessarily better. They do have less side effects, but it hasn't really shown the promise that I think a lot of people thought it would have in the early 90s. And in fact, when we look at the number of references in our literature to treatment-resistant psychiatric conditions, basically starting in the 1980s when things started shifting, the number of references in our literature basically doubled every 5 years, from 36 in 1980 to 1984, 96 in the next 5 years, 257, 503, 761, et cetera, et cetera. I think reflecting the limitations of a very biomedical approach. Now, you notice that the curve has begun to turn a little bit, and I had just recently found this, but I had predicted it because I think the field reached its apex in their reductive approach at the very end of like 2009 into the beginning of 2010, and the pendulum has been swinging back towards a more integrative way of thinking of what we do for the last 10 years. So I anticipate that may level off. And we know that medication outcomes are shaped by a wide range of psychosocial factors. There's prescriber effects, there's characteristics of the pill, the setting of administration counts. That's why we do multi-center trials, because in the 1950s already we understood that if you did the study in one setting, you could get no difference between the pill and the placebo, and in another setting there's a fantastic difference. So things like that end up counting. Non-clinical patient characteristics, by which I mean they're not necessarily features of the illness itself, but they're features of the person or their environment or things like that make a big difference. And of course, the therapeutic alliance also makes a big difference. And I'm going to go into the data around all of this. And I just want to start with this study done by McKay, Emmel, and Wampel. They didn't do this. They did a secondary analysis of the TDCRP data. Now, the TDCRP, for those of you that are old enough, was the Treatment of Depression Collaborative Research Project. And before STAR-D, it was the largest placebo-controlled multi-center trial done, supported by the NIMH. So basically the predecessor of the STAR-D. McKay, Emmel, and Wampel did a secondary analysis looking at the data there through the lens of who the prescriber was. And they found that physicians accounted for greater variability in outcomes than did the medication condition, that the effects were additive. So, and interestingly, through a statistical technique called linear hierarchical modeling, they were able basically to stratify the prescribers. So if a prescriber got a good result with a patient, that prescriber tended to get good results with all the patients. And if a prescriber got a bad result with a patient, that prescriber tended to get bad results with all the patients. And then there were people in the middle. So there was something about the prescribers that lent itself to their effectiveness or relative ineffectiveness. And this was across both placebo conditions and medication conditions. The most effective prescribers using active drug got the best results, and the least effective prescribers using placebo got the worst results. But, and I just want you to think about this for a second. In that study, the top 1/3 of psychiatrists got better outcomes with placebo than the bottom third got with active drug. Okay, just think about that for a second. And then remember, these are placebo-controlled, regulated trials. So it's not like one group of doctors was spending an hour with patients or doing psychotherapy. Like this is very scripted. So the things that these doctors were doing to get better results were pretty subtle. And you know what they were doing? Neither do I, right? Because this is not the kind of thing people put money into, and nobody's getting rich out of finding that. Process research is difficult and complicated, so we don't really know. But I'm going to try to spend the rest of the hour filling in something that we do know from other places about effective prescribing. And actually, if anybody has questions at this point, this would be a good time to let Dr. Santapietro know, and he can jump in with those questions.
Well, and I actually, there's a question that has come up, David, from Adrian Bentman, who you know, and you may get to this, but it's how do you see these issues playing out in split treatments? What tends to get held in each silo? What are the unconscious kind of pushes and pulling going back and forth? And there's more to the question, but that basically is the question. I don't know if you're going to get to that, if you want to address that now.
I mean, I'm laughing because that's a whole other talk. That's an hour. I could spend an hour talking about those kinds of dynamics and how they relate to, family dynamics and dynamics around splitting, things like that. I will get to, I suppose, the most superficial thing that I could say that wouldn't take up the rest of my time is that in terms of alliance, at least, there's alliance, but I think triadic alliance is a really important part of what we do, like the extent to which we are the, therapists and prescribers are working on a shared goal and communicating and all of those things. I think it really contributes towards, better outcomes. And I am going to talk to some length about the impact of alliance. But I'm going to start with talking about characteristics of the pill and how they affect outcome. We know that things like color makes a difference, right? In Western cultures, red pills tend to have energizing effects. Blue pills, tend to be calming or antidepressant. And in most cases, the Cataneo did a study in the early 70s where it turns out blue pills are not calming in Italy. The speculation as to why is that for many of us, blue is a color of calm, tranquil skies or tranquil seas. But in Italy, the Italian, which is a soccer-crazed country, the Italian team is the Blues. So in what they found is that for Italian men, blue pills do not have that same calming effect because blue is a color of power and masculine vitality. We know that expensive pills work better, and there's a number of other factors around pills that make a difference. And this is not just a interesting finding. This is really important for us because it has implications for our work, for our how many of our patients go to the pharmacy and last time their pill was blue and this time it's white or yellow or whatever. And we know that according to a study by Brenda Roman that the majority of patients report decreased intention to continue medications when there's been a generic substitution. It doesn't mean they stop, but if we ask them, how likely are you to stop? The majority of patients will state they're more likely to stop since they've, the color or shape or size of their pill changed. We also know that 34% of patients experiencing generic substitutions will experience new adverse events, either side effects or an experience that it doesn't work as well. And it's not because 34% of the time the generic is always worse. I think that a lot of that has to do with the experience in the patient of some kind of powerlessness, which I think often translates into big problems for our patients and their use of treatment. Placebo, especially with antidepressants, placebo effects account for a large portion of antidepressant response. And again, a number of people, Kirschmore and Scaboria, Kahn, Warner and Brown, Kirsch and Saperstein, looked at this and from the perspective of the most unbiased sample they could find. Normally, of course, we have the problem of publication bias where things that show a positive response for drugs end up in the journal. And as we know, if it doesn't, it, gets kind of falls off the desk and into the garbage can and never sees the light of day. But for new drugs that are being submitted to the FDA for approval, you basically register the study and the FDA gets that study, whether it's a positive or a negative result. So they looked just at that sample, which is relatively unbiased. And using that sample, they found that somewhere between 75 and 81% of drug response, antidepressant drug response, is due to the placebo effect. Now, it's actually important to remind everybody, of course, that placebo does not mean imaginary. Placebo effects are real. They're potent. I mean, you can lower blood pressure. You can cure ulcers. You can, stick a needle in a nerve and measure decreased pain transmission in the nerve with placebos. So placebos are producing real beneficial effects for our patients. And so the fact that 75 to 81% of antidepressant drug response is due to placebo, to me, that puts a burden on us to really know how to optimize that so that our patients can do better. I mentioned that non-clinical patient variables affect medication outcome. And, as the cartoon says, I'll pause for a moment so you can let this information sink in. And it's actually just this point of the slide is just to overwhelm you a bit with a small piece of what we know about things that patients bring into treatment that are going to affect how well their medications work or don't work. And I'm going to go through some of these things in the next 10 slides or so. So we know that patients that are more neurotic are going to have a poorer antidepressant response. Patients with immature defenses, so people who tend to rely on splitting, projective identification, will also do worse with antidepressants. Patients with an internal locus of control, people who feel like they're kind of in charge of their own life, tend to do better with antidepressants rather than worse. And similarly, patients who are low in sociotropy, so these are patients who are not that concerned about what people think, they're not so concerned with pleasing people, but they're more interested in kind of running their own lives and being in charge of themselves. Those patients tend to do fairly well with antidepressants. So about 3/4 of them will have a positive antidepressant response, whereas the patients who are more sociotropic and less autonomous, only about 1/3 of them will have a good antidepressant response. So these are the kinds of things you might want to know when you're meeting new patients, is basically how they function, because it will help you know something about how medications are going to work for them. We know patients' attitudes certainly affect outcomes. So patients who have really high expectations of treatment tend to do well, whereas patients with low expectations don't do as well. And that also that negative expectations tend to promote nocebo responses. So if people think they're going to be harmed, they're much more likely to be harmed. And we also know that the patient's theory of illness is going to make a difference for outcomes. And maybe seems like a paradoxical finding, but patients who view their illness as non-biologic tend, at least when they're mildly to moderately depressed, tend to have better outcomes than patients who think of their depression as biologic. That distinction disappears when patients have much more severe depressions. And I think this relates maybe to what was in the previous slide and the coming slide about how whether or not patients feel like they're, that they can mobilize their agency in the service of getting better. And we know that the biological theory of illness has consequences. A biological theory, depression is due to chemical imbalance or, short serotonin transporter alleles or whatever, has been a story that has been promoted, pretty hard for the last 20, 30 years, not just by drug companies, for their own, reasons, but I think also by national campaigns that are well-meaning and intended to reduce stigma. But by the law of unintended consequences, some other things happen. While it does increase the social acceptance of drug treatment, and it may, in some studies, but not all, reduce the patient's self-blame over having, depression or anxiety or psychosis or whatever. What it turns out is that in most other ways, it tends to exacerbate stigma. So it increases social distance. So if you take people who ascribe to a biological theory of illness, those people are actually less willing to accept a mentally ill person into one's neighborhood or one's family, because it does create, as I said, I think a sense of biological otherness. It also increases the perceived dangerousness and unpredictability of people who have psychiatric illnesses. I think, well, again, because the assumption is because it's biological, you don't have a lot of control over it. It's the biology that's running things. And so actually that way of thinking of it has ultimately backfired and worsened the stigma that a lot of our patients face rather than lessening it. And so that harms our patients at that level, but I think even a more individual, personal level, it does the same thing. So Kemp, Leichel, and it says Downing, I meant Deacon. Kemp, Leichel, and Deacon in 2014 did a study of college students that had a history of depression. The putative point of the study was to determine whether depression was biological or non-biological in origin. So somebody would come in with a white coat, they take a cheek swab, disappear for 15 minutes, come back, 15 minutes later and say, the genetic testing suggests that you have a biological depression or not a biological depression, a psychological depression. And it turns out that in this study, the biogenic theory, first of all, it failed to reduce self-blame of those patients or students, but it also increased prognostic pessimism. So patients just felt like, I suppose in a way, more doomed because they had a biological depression, which they felt, well, what can I do about that? And we know the relationship between prognostic expectancies and actual prognosis is well established in lots of studies. It also worsened mood regulation expectancies. So patients just felt much more like, well, how am I supposed to, do anything or control my mood? Like I can't do anything. So it starts to become the doctor's job, not the patient's job, to get themselves better. And it also decreases self-efficacy. So again, there's several different kinds of studies here, but all of these showed that basically the biogenic theory tends to make people feel much more helpless in relation to their illness, which is not good for them. We know that the interpersonal positions that patients adopt habitually affect their medication outcomes, or that they adopt or that they're put into. So patients who are come from socially disadvantaged groups tend to have higher nocebo response rates. Similarly, patients who are acquiescent as a personality trait, so these are the people who basically feel compelled to do what the authority or other person wants them to do. These people tend actually to have initial placebo responses because we want them to. But as they start to feel the drug moving around in their body, they tend to have bad experiences with that. They experience nocebo responses, I think partly, again, in relation to the experience of powerlessness. Or, you could even say that these are people who can't do a very good job of saying no with their mouths, so they end up saying no with their bodies and their symptoms instead. We also know that patients who have dismissive attachment styles tend to do worse. Patients with secure attachments have better responses and earlier responses. Patients with dismissive attachments, these are, of course, the kinds of patients that we all know who they give you one strike and then you're out. And they tend, a study which looked at not psychiatric medications, but diabetic control, found that patients in that group were much less likely to adhere to treatment, had much worse diabetic control. And the interesting thing about that study, though, was they also found that there was an interactive effect with good communication, so that doctors who were particularly good communicators were able to erase the negative effect of the attachment style. And so again, if we know already when somebody's coming in that they're the kind of person that gets rid of people at the first sign of trouble, that's somebody I really need to pay special attention to good communication if I want them to have the best outcome they can have. Ambivalence also can lead to all sorts of problems with medications, and that includes both ambivalence about medications, but also ambivalence about illness. In terms of ambivalence about medications, interestingly, P. Gay, a sociologist, interviewed 140 or something people about their antidepressant treatment, and it turns out that 15 themes came out of this, and like the top 3 had to do with harm. Further down the list were ways medications helped people, empowered people. So our patients, if you just, you look at how their minds are working, they're thinking more about how our treatments are going to harm them than help them. And so they're ambivalent. And we know that the degree of ambivalence is directly correlated with noncompliance. You don't have to be Sigmund Freud, I guess, to guess that one. Patients with early ambivalence are 2 times more likely to discontinue medications and 3 times more likely to stop their medications if there's any kind of side effect. And of course, also patients who think of medications as stigmatizing in some way are also much more likely to have issues with adherence. And our patients are also, they're not just ambivalent about treatment, they're ambivalent about their illnesses. I mean, I know in my practice, when there are people who are particularly treatment resistant in some way or other, it turns out often to be the case that there's some, lemonade that gets made from those lemons. A lot of my patients, I think I would say, in some way or other have turned out to be far, far more powerful as sick people than they were as well people in terms of, getting out of onerous responsibilities or getting cared for and things like that. And we know that patients with secondary gains are less likely to recover. And we know that patients who are not ready to change don't do so. The Pharmacotherapy Alliance. Well, actually, let me stop where we were for a second and see if there are questions.
Because I'm actually getting overwhelmed with questions here, David. So for people who are really enjoying this, we're not going to be able to get to them all. There's certainly a lot of interest in hearing more from you. I imagine you're going to be doing this. What are the different characteristics, prescribing and/or just characteristics of, prescribers in the top third versus the bottom third? About medications specifically, do you have any thoughts about patients who want brand name only? There was a question about, do you have any thoughts about why there's so much polypharmacy in psychiatry versus other? Let's just go with those for now.
Okay, yeah. Now, so the first question, I've already forgotten the first question about.
Well, the very first one, I would let go because I think you're probably going to get to the characteristics of the prescribers in that study.
Yes. Well, I can say the only concrete evidence we have, the authors of that study did a larger analysis, not looking specifically at the prescribers, but looking at everybody in the study. And it did turn out that people who had a psychological model of mental illness tended to get better results with their patients than people who had a biological model. They didn't break that down specifically in terms of the prescriber, so we don't know if that applies. But I would think it probably would, because a psychological model positions us, I think, to be much more flexible and responsive to our patients than a biological model. Second question was
brand name only. People have patients that want brand name. I'm only going to get better if I have the brand name Xanax.
Well, I can say that from the minute a patient walks into my office, I am educating them about this stuff. So I am drilling into their heads in 20 different ways that they bear a lot of the responsibility for the outcome of this treatment. It's not just about the medications I prescribe, but it's about how they relate to me, how they relate to the medications, that meaning factors make a difference. So that when there's something bad is happening, we don't just assume it's about the medications. We can step back and think, is there something going on between us? So very often my starting place with a patient who says, they've seen the commercial for, whatever the latest thing is, and they come in and they say, I really want Abilify. My starting place will be, you know what? I think Abilify is exactly the right medication for you. And let me tell you why. It's not because it's any better than any other medication. They're all basically equivalent. It's better because it's the one you want. And the research shows us that the medication you want is going to work better than the one you don't want. Now, of course, it's also 5 times more expensive, and you're going to have to pay for that. So, let's think about what's going to be best for you. But I want to, in that, empower them, and I want to be drilling it into their head that the way they think about treatment is going to affect the outcome potentially in very profound ways.
Great. If I can get two quick ones in. One is back on I guess it was the McKay study, or, what severity of illness were we talking about in that study? Did it include, did the studies include all kinds of mental illness, or was it more depression and anxiety and less
The
severe?
McKay study was a treatment of depression collaborative research project, so it was specifically depression. And I would say 85% of the research done on meaning of medication has happened in patients who are depressed. Substance abuse is another area where there's a kind of a bigger focus. But much of what I'm talking about has to do with the depression literature. And I believe in that study it was fairly heterogeneous, so moderate to severe depression, I think.
And then last question, this is on defenses. People with primitive defenses and reduced agency are less med responsive. Is this because of an error in diagnosis, perhaps, an error in understanding what ails the patient? Are there people in neurobiology or neuroscience studying what makes this response poorer? Are the brains different?
That's a great question. I don't actually know the answer to the last part of that, but presumably, these are patients who have a much broader range of impairments. They are depressed, but there's lots of things that are depressing, like poor interpersonal relationships are depressing, and so patients like that, I think part of it is that there's a lot of other stuff that needs to be addressed that isn't addressed by medications. Another piece of it is probably that people who tend to have fairly primitive object relations, are relating to their doctors and relating to their medications in ways that, are, these very stark images of good and bad. And, medication is, like with these patients, if you're a little disappointing, suddenly, you're not worth anything, right? And I think, they may relate to medications in this way. So there's a lot of stuff that's happening with those patients. This is all conjecture, of course, on my part, because that wasn't what the research was addressing. But I think, you can see how your patients operate and imagine there's lots of ways that those primitive defenses would interfere with, good pharmacotherapy.
And if I can just get one quick one in, somebody's just asked, given your, research and thought process around this, do you have a position on the use of active placebo in treatment? Given that it can be effective?
Yeah. Well, I'll tell you about the patient who got me interested in this. Was a patient who was extremely sensitive to side effects. Every medication. I started her on an eighth of a normal starting dose of Wellbutrin, bupropion, and still she had side effects. I didn't know what to do. I was a fellow at Riggs at the time. And I consulted with one of the psychopharm gurus in New York, Don Klein, who said, knowing that this was a psychological issue, said, make it a placebo. Tell her you're going to give her a placebo, and that at some point it will be an active drug. She just won't know when. And try to sneak this in under her defenses that way. So we were really clever, and I was so pleased with myself, and he was pleased with himself. The problem was she was so much more clever than we were, because suddenly she developed an allergy to the methyl cellulose in the capsule, and so right away had side effects. So there are roles for this, but I do believe our antidepressants, I think the evidence shows that for many of our patients, they are at least somewhat helpful. So, why wouldn't you give the maximum that you could, both the placebo side of things, but also whatever the benefits are that the medications do offer our patients.
Great. Thank you.
Okay. So I want to talk a little bit about the Pharmacotherapy Alliance. And for starters, just to say the Alliance is obviously not the same thing as compliance. And we know that, again, Krupnik, Satsky et al. Did a secondary meta-analysis also of the TDCRP data. They had done some alliance measures in that study. And it turns out that, first of all, they figured what they would find was alliance was like a big deal for psychotherapy and probably wouldn't, impact pharmacotherapy outcomes very much. But it turns out that alliance is an equally powerful factor in pharmacotherapy as in psychotherapy. And again, that alliance was a stronger determinant of outcome than drug condition. So patients who got the active drug and had a strong alliance with their doctor did the best. Patients who got the placebo and had a poor alliance with their doctor did the worst. But in those other two middle cells, the patients who had a good alliance with their doctor and got the placebo had greater reductions in depression than patients who had a bad alliance with their doctor and got the active antidepressant. So it's really important. And there's a few elements of an effective pharmacotherapy alliance: warmth and presence, autonomy support, agreement about targets, respect for treatment preferences, shared decision-making, and good communication. And I'm going to go through some of these things. We know that the doctor's empathy makes a difference. And interesting, you'll see, like a lot of this research was happening when psychoanalysts were running the show. We were interested in how these things affected our patients. And as soon as pendulum started swinging, this kind of research dropped out for 20, 25 years. But we know the empathy makes a big difference. The more invested we are in our patients and they're getting better, the more likely they are to benefit. Our own attitudes about drug therapy make a difference. So the more skeptical and this is the one place I think where I'm probably not as effective as I might be, because I'm just very aware of the limitations of our medications. But positive attitude about medication effectiveness helps our patients. I think especially our early patients who are more treatment resistant, we can talk about why that probably isn't true. But patients who are basically treatment naive, I think, benefit from some optimism on our part. In terms of warm human engagement, this was an interesting study done by Cruz in 2013, where they just recorded intake sessions, audio recorded intake sessions. And then they had raters just listen to the tone of voice of the psychiatrist. And turns out you can listen and hear, does that person sound warm or not warm? Does that person sound supportive or not supportive? And it turns out for every standard deviation interval above the mean, there was a corresponding 162% increase in appointment adherence. So when those patients had a warm-sounding doctor, they showed up for their second appointment. And it's amazing that the field isn't all over this, because ideally we'd like our patients to show up. And also another study by Rosen, Nakash, and Allegria, they looked at techniques during an intake assessment into a psychiatry clinic, and basically there. And if the intake person interacted with the computer even once while the patient was in the room, that was coded as a session with technology interaction. If the computer wasn't touched, it was a session without. And it turns out that if there was interaction with the computer, there was, first of all, there's significantly lower measures of therapeutic alliance, and it really resulted in a significant reduction in treatment continuation, whether patients would show up for a second and third appointment. If there was no interaction with the computer, 77% of patients came back for a second appointment. If the intake person was interacting with the computer even once in this study, only 27% of patients came back a second time. And this, of course, is a treatment model that we've adopted across the board without really knowing yet what impact it will have on our patients. And I think, of course, there's ways that, that was one study and, we don't know what else was going on. And I think there certainly are ways we can attempt to overcome those negative effects by recognizing the computer, by being warm with our patients, et cetera. But it's a direction the field has gone in that probably is adversely affecting a majority of our patients. We know that patient autonomy promotes positive treatment outcomes. So more patients are getting better for themselves because they want to, the better their outcomes are. And it turns out that we have a role in that. First of all, this is associated with treatments across the board. So autonomously motivated patients do better in IBT, CPT with medications. And it turns out that this is potentially a more potent factor than alliance. And also that patients feel more autonomously motivated for treatment when they have autonomy supportive doctors. So the more we support that in our patients, the more they find their own motivation for getting better, the better they get. And, there's ways we do this. We were touching on the question before of, what do you do around patients' treatment preferences? And it has big effects. So we know that patients receiving their preferred treatment modality do better. Now, I'm not talking specific medications. This study looked at medications versus psychotherapy, but it's quite powerful. So Coxis et al., they found that patients came in, they did a battery where they expressed their interest in medications or psychotherapy, or that it didn't matter. And for patients patients were randomized into one or the other. So patients who were randomized into their preferred treatment, about half of those patients got better. It turns out, however, that when patients who wanted medications but were given psychotherapy, only about a quarter of those patients had a positive treatment response. And then when patients who expressed a preference for psychotherapy were given only medications, 7.7% of those patients had a positive treatment response. So again, it says something to us about the importance of really listening to what our patients want, because a patient comes in with depression and we're barreling towards medications when they want a different treatment. Chances are we're not going to end up being terribly helpful towards them. And we know the patients who get their preferred treatment respond more rapidly, at least with antidepressants. And that in a study by Lowe, one objection is, well, I don't have time for all that. But it turns out that in primary care, at least, eliciting patient preference does not seem to increase the time required for consultation. Another objection, I think, around these, I'll actually get to that. Patients who are given a non-preferred treatment are also more likely to discontinue treatment. It doesn't take a lot. There have to be Sigmund Freud to figure that out, and they'll miss follow-up appointments. And interestingly, we know that minorities are statistically more likely to prefer counseling, but that they tend to be given less information about treatment options, and we engage them with a communication pattern that perpetuates patient passivity. So again, we have to be mindful of all of the implicit biases that we carry and that are in the treatment systems that we're in, because it affects our patients. And involving patients in decision-making makes them 2.3 times more likely to continue treatment. This is a study that actually came out of your institution there. And they're 7.3 times more likely to continue treatment if they are given a role in decision-making and in agreement with about the diagnosis. And in this study, the involvement in decision-making was as simple as, do you want to take this medication once a day or 3 times a day? Just doing that increases the likelihood that patients will continue taking their medications. And we know that these patients who are involved in decision-making have improved outcome at 18 months. And one of the objections is, well, I can't let my patients dictate, the treatments they're going to get. They can't, I can't listen if they come in and say this, they want this or that. But Clever did a study looking at, again, primary care physicians who involve patients in decision-making. Turns out those treatments ended up more consistent with treatment guidelines, not less. And we know that skilled communication enhances adherence. So, a clear communication about, this is what it's going to look like, this is how long it's going to take, this is what you may experience, including information about side effects. Now, patients who we tell about side effects are more likely to have side effects, but they are also more likely to continue taking medications if they have side effects, because we've made that part of the doctor-patient relationship and grounded it in something that makes it feel less scary. Effective communication is also collaborative, non-authoritarian. And as I said, this is especially important in specific populations like patients with a dismissive attachment style. And we know also, well, actually, that's maybe another place to stop if there's other questions.
Yeah, let me again, a lot of material coming in. A lot of question about whether you have thoughts about Zoom, and given and actually my first thought, David, it's amazing to me that we don't hear about it once a week or once a month. It seems like I think last time I heard you speak was at the Riggs last year, and a whole year has gone by, and I've heard nothing, and we've not been talking about this stuff, and it's so powerful. One question is whether you have a comment about the Zoom world we're living in relative to, basically like patients and or our own kind of relationships.
I would imagine you guys are probably talking about that nonstop, the way we are at Riggs, and thinking about the effects it's having on our treatments. And of course, it's, we operate in reality, right? So we have to adapt to the reality we're in and make the best of it. And, for some patients, it's a big deal, to have the person present, to be able to see. I mean, I really miss being able to see, is somebody's foot moving while we're talking? It gives you so much information that the patient isn't communicating in words. But there's a range. I've had other patients who are like, this is great. It's like, I'm right here, they're like, I'm almost in their lap, and they think that's the best thing. And for other people, another patient of mine, wanted me to back up because you've probably noticed I gesticulate a lot. And that she wanted to be able to see my hands, because that way she could tell how, invested I was. And I look forward to a time when we're back in the room with a patient, because I think, it's probably, for most patients, it's probably better for them. But again, it's worse for them if we're giving them COVID. So, and I just haven't said anything that you all don't know already, right?
Well, I mean, it's new stuff. I mean, the study that you mentioned about the computer, I mean, it reminded me, there's this awfully, sort of dark, in a sense, thing that was going around on Twitter. A kid, I think 4 years old, drawing, asked to draw her visit with, what it's like to visit with a doctor, and she drew a doctor on a computer. So the technology really being, distracting from the task. And you're talking about with Zoom, trying to incorporate it into the task in a different way. There's a question about lots of good ideas that, things that separate out, the art of prescribing, empathy, voice, patient autonomy, patient preference. But what, basically the question is, what can we do with that? Like, do people have to go to boot camp? Is it something that can be practiced? How do you, what's your recommendations for people that, that aren't at Riggs, where you're living and breathing this stuff and all the time, but you're really trying to have an impact out there? I mean, what can make a difference?
Well, I mean, I think on one level, like I said at the beginning, when I apologize that you're not going to learn a whole lot, I would bet most people on some level know a lot of this just in their bones as human beings, right? But we're operating in systems of care and really want us not to know it, right? So, I mean, part of it is just, just starting with a recognition, our interest, our concern, our respect, our giving patients, respecting their agency, all of those things, which we were taught how to do as kids, right? Hopefully, getting into psychiatry. And just to remember that it's important, that it's not all about the particular medication we choose. So much of it is about this. And you don't have to be at Riggs to do that, right? Each and every person who's on this, in this talk here, I think knows something about how to do this. And the other bit of it is, like I'm trying to familiarize you with the literature. I was saying to John before this started that, we're in an era where we're very concerned about evidence-based practice, and for good reason, But when we say evidence-based practice, we're talking about a specific corner of the evidence base, which is about which medications work for which symptoms. There's this whole other evidence base that I'm presenting today that is about, not what to prescribe, but how to prescribe. And I think if we're not like going out of our way to look into that evidence base periodically, we are not really practicing evidence-based medicine. So the other thing you can do is just, read things on the topic, when it comes across your desk, or read books or read papers. And I'll throw up a couple papers at the end of this talk there where I discuss a lot of this evidence base. But I think it's something that, really all of us should be doing. Other questions? Hello?
Sorry, I was on mute. I was on mute. There we go. It's the Zoom world. A comment just came in that it's one of the things refreshing about your talk is to see studies that actually confirm, people's intuition, which isn't always the case. One quick question. Do you have anything specifically to say about PRNs? The use of PRNs? I mean, everything kind of applies in the same way, or anything specific or different?
Well, that's such a broad question. I could come at that a million ways. But, I think one of the things that I'm interested in doing with my patients is empowering them. I think the more empowered the patient is, the better off they are. And then the question becomes, are they using PRNs in an empowering way or a so I'm all for patients using PRNs, like being able to experiment with, well, what happens if I don't use this? What happens if I take less? How can I? And I think of that. I often think of that through the lens of what most of us have heard about is the idea of the transitional object. A lot of our patients, they're less anxious just knowing the Ativan is in their pocket, right? As long as it's there, and they could use it if they needed it. They're calmer. So you don't always have to take a medication to benefit from it. And I want to work with my patients to help them recognize how much of that self-soothing capacity is in themselves, how much of that capacity to manage is already there, and to be working at expanding and developing that. On the other side, there are people who take PRNs every time. There are patients who it's almost like they don't have feelings anymore. They just have symptoms, right? Like every time they have a bad feeling, like if I do something and I feel guilty, that's information, right? That tells me I probably shouldn't do that again, right? But I work with people, and I imagine you do as well, that they do something, they feel guilty, and what that means to them is I got to see my psychiatrist because I'm feeling bad. And so, in that case, that kind of use of medications, I think we have to work with around translating back from like problems of illness to just problems of living, and the idea of the signal function of emotions, that our emotions have evolved over hundreds of millions of years because that's our sense organ for feeling our way through the social world. So, you want to work with patients, I think, in a way that they're not undercutting their own capacities and development.
I love that idea about, is it empowering or disempowering? So we'll let you get back. And we've got about 15 minutes total, so I'll let you go where you want.
Okay, yeah, I think I will be able to finish in the time allotted. But if I don't, we had a discussion. So I just want to say medications, and this is like along the lines of what I was saying about disempowering uses. So patients can use medications defensively against self-knowledge. So in a study by Gibbons and Wright, they did an interesting thing where they took college students, they gave them a bunch of batteries, one of which assessed their level of sexual guilt. And then they gave them a substance and said, this might make you feel a little bit weird. And then they had them do a bunch of other things, one of which involved viewing some pornography. And then when they asked the patients afterwards, like what the medication did for them, the patients who were high in sexual guilt responded, wow, that medication really made me horny. Of course, it was just, it was a total placebo, but they were motivated to attach, whatever disavowed parts of themselves to the medication, so they didn't have to know that, these things were actually exciting to them. And our patients can use medications in all sorts of ways like that, not to know things about themselves. And then, Elvin Semrad, who was a teacher of my teachers, I think, people may have heard this, but, he described the encounter between the patient and the doctor. He said it's an encounter between a big mess and an even bigger mess, right? And, we're all unconscious, all of us. We all have our stuff. And our patients are struggling with big, powerful, distressing feelings. They tend to evoke the same kinds of feelings in us. Our angry patients make us angry. Our helpless patients make us helpless. Whatever they don't want to feel, they're trying not to feel through projective identification. They make us feel. So, we're also prone to becoming irrational. I mean, in this ad from it's now the 70s probably. If she calls you morning, noon, and night, day after day, to allay her chronic neurotic anxiety, try her on stelazine. Right now, whose anxiety is actually being treated in that ad? And we know, for example, in a study by Waldinger and Frank, that for difficult to treat patients, patients with primitive defenses, and at least in their study, countertransference factors seem to outweigh rational decision-making factors. I see this certainly in my work that when a patient comes into Riggs and they're on 2 antidepressants and 2 antipsychotics and 2 mood stabilizers and a GABAergic anticonvulsant and then something for sleep, and of course they're so sedated from everything. They're also on a stimulant, and you guys probably see these patients as well. When I see that patient, my first thought is, wow, this patient has made some poor doctor suffer an awful lot to end up with a medication regimen like that. And so we need to be aware of that. And one thing we can do, and talking from things we can do, like I write a small psychodynamic formulation on every, 3 lines, really just limited to how I think it will affect their use of medications, because it helps me stay oriented. And Trellower found that it really helps us preserve empathy for these kinds of patients. Interestingly, she was a CBT researcher, and what she did was she taught frontline mental health staff working with chronic self-mutilators either a CBT formulation of self-harm or a psychodynamic formulation. And this kind of mirrors some of the research where, with CBT, when you stop CBT, the benefits start decaying over time, and eventually often will sink to non-significance. Whereas if you stop a psychodynamic treatment, it keeps still getting better and better and better for about a year before it levels off. And she found a similar thing that mental health staff who were taught a CBT formulation, it gave them empathy, but after 6 months that had decayed to non-significance. But a psychodynamic formulation of self-harm was preserved over time. And I think I'm done, so we have time for questions. I mentioned some papers that you guys may, if you want to look at some of this evidence base, especially the Mintz and Flynn really goes into the evidence base. The other two are thinking a little bit more about kind of the dynamics of how of treatment resistance around medications.
Great. So, David, we have another question. This one from a trainee, and again, great talk. How should this, what you presented, the data, the studies, be reflected in how we train future psychiatrists?
Interesting. I just floated a question to the ADPERT listserv, the residency training director listserv, last week about, how, are people making this an explicit part of psychopharm supervision? Are we recording anywhere? Is anybody recording psychopharm sessions and doing process work the way we do with psychotherapy supervisions? And I basically didn't hear anything. So I take it that we're probably, usually program directors are happy to show off what they're doing. So I took it that we're probably not doing enough around teaching students the importance of this stuff. But as I said, I think the pendulum is swinging. So I think that, so I'm hopeful that as a field, we're moving towards a recognition that this level of treatment is important. So there certainly is more we can do. We can certainly do more teaching these evidence bases. And I think we can do more around the individual supervision of psychopharm, teaching students, to be paying attention to the alliance, to be listening, to be empowering, and to do all those things.
Okay, so I'm going to try. So Kevin Young, who leads our psych testing, has been sending in a bunch of comments and questions, and sort of his question about research. And if I can figure out how to unmute him, and if this is the right Kevin. Kevin, can you talk? Can we see? Are you on?
Is that working?
Yep, I can hear you. Go for it.
Thank you. Love to talk and lots of questions, and love to chat another time too. The one that I was just thinking about is, and this isn't necessarily research, but is there a role in trying to update providers? Is there a role of peer supervision, of observation, and kind of making folks aware of their patients' feedback? I'm thinking even, you're on an inpatient unit, you have a patient for a brief period of time. You have time pressure, but that interaction, that style is so important as to what you do and what the outcome is. Have people looked at increasing performance, improving quality by doing direct work with their providers?
Certainly there's research on this on the psychotherapy side of things. I don't think there may be research on it that I haven't come across on the psychopharm side, but I can say in terms of, like one of the things I say to every patient in my initial spiel to them, like I'll talk to them about the meaning effects in medication and the importance of the doctor-patient alliance. And so I will specifically authorize every patient, if I'm doing something you don't like, I need to hear about it, because if I'm not hearing about it, chances are it's having a negative effect on how your medications are going to work if I'm doing things, that are rubbing you the wrong way. So I think it's a great idea for us individually, and you could also, do it other ways, but to really authorize patients to say, let me know what you don't like. I was on a panel, and a patient had a doctor say this to her after like 10 other doctors, and she didn't feel like she had permission from any other doctor to complain about the way that the treatment was administered. But this one doctor had kind of given her explicit permission, and it was a very powerful experience for her. So I think we should certainly, one of the things we can do to be very, very helpful is to, let our patients know that we are interested in their feedback.
Kevin, any follow-up for that, or is that good?
No, that's great. I mean, I have other questions, but I can defer to other folks.
Why don't you ask one more as I'm texting back and forth with some people?
Sure. Just another quick question. I know at Riggs that all patients get psych testing at admission, and I just wondered, do you use, when you look at like the role of personality, the role of these different characteristics of the patient, do you use that in your in how you interact with those patients? Because I'm just thinking, I'm always motivated with psych testing. If we increased access to psych testing at admission, perhaps then we could inform and use that, in our interactions with our patients around prescribing.
I could see a role for it. I mean, I think I rely much more on the way that the patient's dynamics are playing out in the room with me, and then I'm drawing attention to it, and I'm using more live in the room for my understanding of the patient's dynamics. And, I'll have, part of the way I would work, which we didn't talk so much about today, but I will, I'll get a brief developmental history, really, what are patients' relationships like? What were the early models? What was caregiving like for them? So as I'm getting to know somebody, I am starting out with a lot of information about, their story and their functioning. Psych testing might be a shortcut to that. Again, I think my preference would be to have that as much as possible be between us rather than somewhere over there in the psych testing. But it's a really interesting idea about whether and how that could be used to more effectively, target. Like, for example, if somebody turns out on psych testing, you get a sense there's a dismissive attachment. That does tell the prescriber, this is somebody who really needs very clear communication.
Okay, let's see if we can get a couple more in here. I've got Hank Schwartz, who you may know, I think, is the psychiatrist in chief emeritus here. And I'm going to unmute Hank. Hank, we should be able to hear you.
Okay, that was just absolutely a terrific presentation. I mean, just one of the most absorbing grounds I've heard in ages. So I'm just curious if you could comment on the work that so many of us do, which is essentially psychodynamic psychotherapy, in which pharmacotherapy prescribing may be a small but constant background note. And comment, specifically about the supervision of that and the divide between the supervisor's attention to the dynamic issues of the ongoing therapy and the dynamic issues of the prescribing.
Yeah, I mean, I think in your question, you've already, you start to have an answer that there are ways. Maybe a stepping back place is to really think about the trouble that we have with the idea of a mind-body split. There are so many things that push us into thinking in disintegrated ways. Even just our language, right? Descartes gave us, in the Western world, we have the Cartesian dualism. We have mind and we have body. We don't have a metaphor for mind-body the way, you might have in some Eastern cultures. And, we have insurers, we have systems of care, we have patient, I had a patient who, when I asked him, so what's this is in an intake. So what's your mood been like in the last five days or so? And he says, anhedonic. Like he was making an argument for me to see him in some kind of dualistic way. And so I think a starting place for us is just to recognize that it takes a lot of work actually to not fall into dualistic thinking. And then, once you do that, then you're in a better place to be doing these things. And I think, there's probably a lot more we could do as a field to really recognize. And, this again, some of the papers that were up there speak to this, to the complicated stuff that's going on back and forth around medication interactions. Tom Gitile talked about what he called the delusion of precision, which is, because medications, we have a mechanism and a receptor, we think of them as concrete and precise and straightforward, and they are not at all. And I think we just need to be reminded ourselves that any discussion about medications is also a discussion about our relationship and a discussion about power and a discussion about agency, and to do a better job at that. And so certainly, obviously, in our supervisions, we would be, our patients would be well served if the supervisors were listening to pharmacotherapy with that ear. But one of the things that happens, especially if you have in split treatments, one of the other things you can get is, a worry, like, I don't want to talk about that because that might be stepping on the pharmacotherapist's toes, or that might be stepping on the psychotherapist's toes. And in the paper, Recovery from Childhood Psychiatric Treatment, which is one of the ones I threw up there, I really talk about the ways that very often the patient's dynamics can fall into the gap, like the real troubling the gap that each discipline decides we're not going to talk about because they're worried about overstepping in some way.
Excellent. All right, so one more question, David. Actually, in a comment before the question, so I'll ask the question. Let's keep you on camera, but after we finish, let's put up the QR code after we stop recording, even so people can see it again, because it flashed up pretty quickly. So this is a forward-thinking, looking question. How do you invite technology to become an asset that could encourage the alliance and compliance?
I can say that is not an area of expertise of mine. I try to use as little technology as possible. I take notes on paper and then put them into my computer later because I really don't want to have that there. But it was embedded in the question about psych testing. How do we share information? It's I suppose embedded in the ways that like I say, I write a little dynamic formulation, that's an accumulated bit of wisdom that I can pass on to the next doctor so they don't have to learn the lessons the hard way. So there's a lot of ways that I think, the ways we share information could probably improve our care.
Yeah. No, that's great. And I think the question speaks to what we're swimming in right now with all of the, all the technology, so to speak. I just want to, and let's see if we can bring that slide up. And as we're doing that, I just want to thank you, David, for sharing the time with us. I think it was extraordinarily engaging. I wonder why we haven't done this, or been talking about topics like this more frequently. And so we'll take that as a challenge that we'll want to rise to, frankly. I think people are going to have some questions afterwards and have asked if they can get in touch with you, and I'm sure you're good with that and around some of the resources and other things as well. So with that, Rob, we can go ahead and stop the recording.